Hi, my name is Junior Ramos, and I am going to talk about the comprehensive molecular characterization of papillary renal cells carcinoma. Definition: a type of kidney cancer that forms in the cells that line the small tube of kidney that filter waste from the blood and make urine. When viewed under a microscope, most papillary tumors look like long, thin, finger-shaped growths. There are two types of papillary renal cell carcinoma: type 1 and type 2.
Decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The
Application in medicine. Type 1 tends to grow slowly and spread less often to other parts of the body than type 2. Patients with an inherited disorder called hereditary papillary kidney cancer have an increased risk of type 1 in papillary renal cell carcinoma. Patients with a genetic disorder called hereditary leiomyomatosis and renal cell cancer are at increased risk for type 2 papillary renal cell carcinoma.
I had the opportunity to participate at the IPSEN Satellite Symposium in Kidney Cancer, together with my colleagues Dr. Bernard Scudier, Dr. Tom Bowles, and Dr. Tony Chueri. And my task at that Satellite Symposium was to translate the data that we have, the clinical report of the phase 3 trial, the Meteor trial with cabozantinib, and the Checkmate 025 trial with nivolumab, how we can translate that into selecting our treatment for patients in second line after failure to one prior tyrosine kinase inhibitors. At that moment, we presented 3 different clinical cases, and in this clinical case, we show different profiles of patients who were candidates to one or the other alternatives. Unfortunately, in this field, we don't have a biomarker, a predictive molecular biomarker that really can help us in the daily clinical practice. So we need to base our treatment decisions in things like in factors like patient characteristics, age, comorbidity, co-medications, or in tumor characteristics, how bulky is the tumor, what is the tumor burden, how fast the tumor is progressing, and of course, the tolerability and the clinical outcome to the first line the patient received. So I really hope the attendees, well, at least they thought twice about what they are doing in their practice.
Thank you for joining us today. Now let's get started. So let's start, Sandy, by talking about what is commonly the challenge for most doctors. They have a patient that's presenting to them. They have to decide when to start therapy. It's a kidney cancer patient already metastatic. And they have to say, when should I start? And what are my goals of therapy going to be? What would you answer to that?
Well, I think you want to really, over the last decade, I've come to realize that you don't need to start therapy on patients right away. So I wait to make sure that there is growing disease. So it's not uncommon to see patients with small lung mets which are not biopsyable. So I'm very comfortable about monitoring and waiting till there is disease. But on the other hand, there are patients who are symptomatic, who have bulky disease. And I think those patients I would feel very comfortable offering them therapy right away. And then there are patients who are young, and clearly there is an anxiety factor as well, which we need to take into consideration. So I think all of this need to be considered before offering patient therapy.
And then what do you say to them about what your goals are with either targeted therapy, an mTOR inhibitor, or other therapy options around them?
I always lay out in my mind what are the goals. So I think about cure as our number one goal. And I think that's important to have in mind. And with the current treatment, and clearly this may change with more immunotherapy becoming available, but I think I offer high-dose IL-2 to patients with an intent of cure. Then if cure is not an option, I also look for those patients who may have oligometastatic disease, where you may offer them some systemic therapy and combine it with some local therapy with an intent for cure, or maybe even long disease interval. So if cure is not an option, we now know with all of these agents that we've had for a decade that we're clearly helping patients live longer. So I think prolongation of survival and delaying progression of disease is a very important objective. And finally, I think quality of life becomes a big issue, especially as many of these patients live with disease during their entire lifetime. All of these should be considerations in deciding which drug you're going to make.
So Martin.
Pros and cons. Pros. It can be cured if diagnosed and treated while it is still located to the kidney and immediate surrounding tissue. The probability of cure is directly related to a stage or degree of spread of the tumor. Cons. When there is distant metastasis, disease-free survival is poor. However, in some cases, certain patients will survive and after surgical resection of a star detector tumor, because most patients are diagnosed when the tumor is still relatively located and amenable to surgical removal. About 73% of our renal cell cancer patients survive for 5 years. Issue applies in Ecuador. Annually, around the world, heat incidence is higher in developed countries and less frequent in underdeveloped countries, such as Latin America. In Ecuador, the kidney cancer is not so frequent.
Sandy, I mean, one of the things that we're understanding in oncology is we're looking for activating mutations anywhere we can find it. Sometimes we look at the tissue, and most recently we're now looking at liquid biopsies. Is there a role for liquid biopsy testing in your practice for kidney cancer, and what would you recommend for the practicing physician?
I think in general, this is a very confusing topic for most community oncologists. We do both the foundation one as well as the guarded biopsy, and I think interpreting those reports can be challenging. I think that they are really prognostic at this time. They tell us that the patient might do better or worse, but they're really not helpful in selecting which drug to give for a given patient. I would advise community physicians that perhaps refer to an academic center for a molecular tumor board, which is sometimes what I do. I take that report and give it to our tumor board, especially to help us advise what the next steps are to do for a given patient.
And you do that at the time when the patient.
Conclusion. Surgical resection is the main component of the treatment of this disease. Even in patients with a disseminated tumor, locoregional forms of treatment can play an important role in alleviating the symptoms of the primary tumor or ectopic hormone production. Systematic treatment has only shown limited efficacy.
Yeah, so we presented Saturday morning results from a phase 1/2 study of a novel first-in-human HIF2 oral HIF2 inhibitor by the name MK6482, which was a proof of principle that we can target that transcription factor. From 55 patients previously treated with clear cell RCC, I would say heavily pretreated, median number of prior line of therapy 3. Were started on 120 milligram once a day of this oral drug MK6482. So the first thing, the drug was found largely to be safe. Most of the toxicities were grade 1 and 2. Anemia was the most common toxicity, which is on-target toxicity due to the fact that this HIF2 inhibitor lowers erythropoietin level. We found also some hypoxias, but we did not find these common side effects received from VEGF inhibitors such as cardiovascular toxicity with hypertension or significant fatigue or hand-foot skin reaction. Now, for efficacy, 24% of patients had responses. So it was a single agent in a refractory setting, which is quite encouraging. Progression-free survival was 11 months. Most of the responses were durable and were beyond 6 months. And what we also presented during this GU ASCO 2020 is, activity of MK6482 based on IMDC risk group. So we saw actually responses in not just the favor risk, but also the intermediate and the poor risk. So this is quite encouraging and led to the development of a phase 3 trial, registrational pivotal trial with MK6482 versus everolimus in patients with refractory clear cell RCC who progressed on prior VEGF TKI and checkpoint block. So the next is beside the phase 3 trial, we are trying to combine MK6482 with other assets such as VEGF TKI, checkpoint inhibitor, and others, hopefully for the next generation of trial, and do some elegant, hopefully, biomarker work to try to understand mechanism of response and resistance, because not every patient responds to these. I think you have to watch for HIF2 inhibition and HIF2 as a target in RCC. We thought for a long time that this is undruggable, but now, luckily, we have a first-in-class drug that works and hopefully more drugs in the future. Yeah, so there are some other interesting renal study. One in particular combines a VEGF tyrosine kinase inhibitor, gravitin, with nivolumab in patients who had prior TKI, encouraging clinical activity and safety, presented by the group at MD Anderson. There has been also multiple abstracts, one from the IMDC, really from Dr. Bakuni and Hang, look at the role of cytoreductive nephrectomy in the era of checkpoint blockers. Again, a very controversial topic, especially with Carcinoma showing no benefit much in the era of sunitinib, but really some elegant work from Dr. Bakuni showing that there are some patients that may benefit in terms of overall survival from taking the kidney out. We have to be very careful how to interpret these retrospective studies, and at least this hopefully will be the impetus to do randomized trial in the cytoreductive refractory space, checkpoint blocker like the one with Dr. Young and Dr. Vaishampayan, the probe trial. So again, very exciting things, and hopefully we'll keep this meeting high level with a lot of new finding and doing.
Thank you.